you for joining us in this room to learn a little bit more about skin-directed therapies. And I'd like to take a moment to introduce you to Dr. Lay. Dr. Lay is a dermatology resident at the University of Pittsburgh Medical Center. So he traveled to be here with all of us and have a great conversation about skin-directed therapies and open it up and really explore the diagnosis and treatments and all of that with you here today. So please join me in welcoming Dr. Lay all the way from Pittsburgh.
Hi, everybody. Very nice to meet you all. Very excited to be here. So I was thinking about the best way of doing this, and I do want it to be interactive. So I felt the best way of doing it is to kind of do it like a common myths, fact or fiction. So I titled this From Lotions to Light, Fact or Fiction, Exploring the Landscape of Skin-Directed Therapies. As I mentioned, my name is Thomas Lay. I'm a dermatology resident over at the University of Pittsburgh. Thank you all for having me. So all these questions Autumn has provided to me, and they're direct questions that we've gone over at the different webinars that the Cutaneous Lymphoma Foundation has done. So I felt that was a good way of kind of tackling and kind of giving a little overview of excuse me, cutaneous lymphoma and treatment. So one question that we've gone is, how do I know if my disease is getting better? This is a great question. So to understand that, we should talk a little bit about cutaneous lymphoma and how we think about it. And so I'm focusing here primarily on mycosis fungoides, which is the most common cutaneous T-cell lymphoma. So when we think about mycosis fungoides, there are three main stages. So clinically, or when we look at it, there's the patch stage, the plaque stage, and the tumor stage. And so here we have what it kind of clinically, yeah, there we go. This is how we see it clinically: a patch stage, a plaque, a tumor. So a patch is a flat lesion in dermatology. That's how we call it. It's a predilection for the non-sun exposed areas like the buttocks, the middle thighs, underneath the breast. Usually we describe it clinically, it looks like little handprints on the skin, like handprints that press on the skin, depending on your skin type. If you have lighter skin, it appears a little bit more reddish pink, but in darker skin types, it can look even a little bit more purple or so. And the patch grows a little bit, it turns into a plaque. And so this plaque is an indurated, elevated lesion in the skin. And then finally, if that grows even more, it turns into a tumor. And these are what we consider almost like firm nodules in the skin. And so that's how we characterize the growth of CTCL mycosis fungoides. And so I've included a diagram of the skin here where we see three main structures, or three main parts of the skin we think about. So we have the epidermis here, the topmost layer of the skin, the dermis, and the subcutaneous fat that helps insulate us. So in the epidermis, I want to give a disclaimer. This diagram is not great because the epidermis actually is quite thin. It's about it's like as thick as like a piece of paper. So this looks thick, but it's not as thick. So ultimately, as you can see in the patch phase, the plaque phase, and tumor phase, the tumor is growing. It's growing through the epidermis to the dermis, and so looking at all of this together, as dermatologists, we characterize the disease based upon how many tumors are there, how many patches are there, and get an overall picture of the state of the disease on a patient. But there are other things we consider as well. Like, for example, there's a special classification we use if the disease covers more than 80% of a person's body. That's called erythroderma. That's a specific classification on its own. And also, what do we have here? We have blood vessels down in the dermis, right? And so if the disease progresses downwards into the blood vessels, it can move into the lymph nodes, it can move into other organs, and that's very serious. And so that's why for some patients, depending on the severity of the disease, some physicians will recommend getting imaging to take a look to see if the tumor has spread to the lymph nodes, spread to other organs in the body. And taking that all together, then we're able to have something called a stage. And so in oncology, cancer treatment, we use the concept of staging quite often. And it's basically a fancy way of saying we want to understand how severe a disease is because it affects the treatments that we use and also affects prognosis. So we're able to figure out from there, like what is the expectancy of how the disease should progress. And so just from an overall view, we use that to figure out if a disease is getting better. So if a patient is more in the patch stage, that is objectively better than if they have tumors. But, you know, the most important factor is you, the patient. And I think this is somewhat hilarious because in the past 10 years in the field of cancer clinical trials, we've discovered that asking patients their opinion about their disease actually is helpful. It's called a patient-reported outcome measure. And so I mean, look, this is published last year, right? This is a systematic review or just a compilation of all the different clinical trials on this topic. And they've discovered, sorry, this is quite small, so I'm just going to read it out. The integration of patient-reported outcome measures into cancer care likely improved overall survival and health-related quality of life with moderate certainty. So what that meant was that when oncologists asked patients, you know, how do you feel about your skin disease? Do you feel like it's getting better? Do you feel like it's getting worse? And incorporate it into their assessment. That tended to help predict how well those patients were doing. So what this means is, you know, you can come in and you can feel as if your skin disease is all gone, but ultimately it's up to you to tell us, you know, I'm itchy, my skin is so dry, I'm not happy, you know. We take that all into account to figure out how well you're doing. So to answer the first question, taking all this into account, that's how you know if your skin disease is getting better. All right, so the next kind of question, myth is, I've heard of a new FDA-approved drug such as mogalizumab or any sort of new FDA-approved drug for CTCL. Why don't I try that? So this image is what came up when I Googled using a sledgehammer to crack a nut. And so I'm hoping to convey here, sometimes the guns are too big for what we're trying to do. And this kind of goes into the theme of why we're here today, a skin-directed therapy, right? So here, we use skin-directed therapies primarily when it comes to like a patch phase treatment or maybe like early plaque phase, you know, because, and I've tried to circle it here, if you are putting like a topical therapy, like let's say topical steroids, imiquimod, nitrogen mustard gel, phototherapy, it can only penetrate so far down. It can't go all the way down through the dermis. And so that's the goal of skin-directed therapy. You know, we're just trying to tackle the most superficial disease because everything comes with side effects, especially these heavy guns, these big systemic therapies. So ideally, if we want to treat early disease, we're going to use skin-directed therapy versus if we're dealing with a tumor phase, like a cutaneous lymphoma, maybe that's when we consider an oral medication, an IV medication, something more severe. But so we try to tailor the treatment based upon the severity of the disease. And of course, it's an ongoing conversation with you, the patients. All right, so here we go more into some fact and fiction, and I heard that people were very interested in talking more about phototherapy. So these are a couple little blurbs about that. So fact or fiction, going outside in the sun is an adequate replacement for phototherapy. And personally, I think this is a little non-intuitive, so it's actually fiction. And to understand why, I think we have to go a little bit into an overview about what phototherapy is, how does light therapy work. So here is the electromagnetic spectrum. And so these are all the different light rays that are emitted by the sun. It's a full spectrum ranging from radio waves here, which are called like long wave radiation, versus gamma rays, which are the highest energy and the shortest radiation. But a majority of light that the sun releases is within this ultraviolet visible infrared range. And this is what we kind of utilize when it comes to phototherapy. And so there are two main phototherapy modalities that we use in dermatology specifically. So we use UVB and UVA modality. So going back here, you can see it's like part of this electromagnetic spectrum that the sun releases. We're using a very specific, harnessing very specific wavelengths from that. And so in UVB, we tend to use what's called narrowband UVB, which is a very specific wavelength, 311 to 313. And then in UVA, we tend to use something called PUVA quite a bit. And that is a therapy that combines something called asoralin and UVA. So asoralin is a parent compound of family naturally occurring compounds known as linear furocuramins. And what it does is it sensitizes your skin so that you kind of tackle the cancer cells or the inflammatory cells more accurately. And so if anyone is a chemist in here, this is a fun diagram to kind of define what's going on. So you have a DNA here, you have your sorolin, and they kind of come together, and with the addition of UVA, they link together. They form these products, and these products essentially damage the DNA and inflammatory cells and help kind of treat any sort of inflammatory disease that you're worried about. And so we use this to our advantage in inflammatory diseases like cutaneous T-cell lymphoma, B-cell lymphoma, and things like that. And it's been found that UV therapy can lower inflammation. It decreases the amount of inflammatory messaging signals in the skin. It's great. It's very useful. So with all this in mind, the question is, why do we use phototherapy over just going outside? Well, there's a couple of reasons why, and one of them is that the specific wavelengths that I outlined in the last slide, those have been found in multiple research studies to particularly lower inflammation. It lowers inflammation maximally, but it also minimizes the risk of skin cancer formation, because that's the other thing we're concerned about, right? We're here in dermatology, we're always concerned about skin cancer, and we want to minimize people's risk for skin cancer. But also, you know, photo aging, no one wants to look wrinkly, no one wants to look old, very important. And so using these specific wavelengths and not utilizing the full spectrum of light like you get when you go outside kind of like maximizes the benefit and minimizes the risk to our benefit. But one other thing too is that sun exposure is unpredictable. Like everyone is all over the US, all over the world, the amount of sun exposure you get, the time of day, the season, and even especially your individual skin type. Like if you have a darker skin tone, you're gonna react to radiation a little bit differently than if you have a lighter skin tone. So all these things are taken into account. And so just when you're getting phototherapy, it's a very measured dose. So we know exactly what we're giving you. I mean, to be honest, for patients that we're unable to provide them a phototherapy box because of cost, you know, it's expensive, we do tell them sometimes to go out and see if it works. Just kind of get some sunlight for like 10 minutes a day. But we do tell them to avoid the hours between 10 a.m. and 2 p.m. just because those times, that's when the sunlight is at its maximal strength, and we want to avoid all that radiation if we can. And so I thought it would just be interesting to highlight too some historical aspects of phototherapy. So sunlight has been used to treat cutaneous disease for like thousands and thousands of years. I thought it was very cool. Many different civilizations, such as the ancient Egyptians and Indians, they've used topical plants and extracts because those contain this compound that I mentioned, sorolin, that sensitizes the skin. They've used that. And so here is, I had to write this down just because I forgot. It's wild parsnip. So the sap from wild parsnip actually contains sorolin. So you just apply it on the skin and then you just kind of stay in the sun. And here is Niels Finsen, who actually won the Nobel Prize in 1903 for his treatment of cutaneous tuberculosis. And so cutaneous tuberculosis in the past was considered an incurable disease, but he was the one who kind of categorized and discovered that you can use phototherapy to treat it, which I think is really cool. All right. And so another fact or fiction is You don't need to wear sunblock when you're going outside if you're using phototherapy. Well, you're talking to a dermatologist. So this is pretty much fiction. Wear your sunblock, everyone. Come on. Like, that must have been an easy one. So here are some guidelines for the American Academy of Dermatology. When you are looking for sunblocks, we get questions from patients all the time. What should I look for? Well, here are some things to look for. You want to make sure the sunblock is broad spectrum. It covers the entire spectrum of specifically the UV rays. You want to make sure it covers UVB and UVA. It should be water resistant if you can. At least an SPF of 30. Sometimes we counsel patients like at least SPF 50 would be better. You want to apply it all over your skin, especially in the sun exposed areas. If you're going to be out swimming, golfing, sweating a lot, you want to make sure you reapply about every 90 minutes to 2 hours. And then, patients say like, doc, are you asking me to avoid the sun? And I'm like, yes. No, I'm just kidding. But you honestly should seek shade if you can. We don't say avoid the sun, but rather just consider it a friend you want over there. So seek shade and make sure you wear a hat. Like it can't be a baseball cap that covers the front. It needs to be big and broad and floppy to cover your head and neck. Very important. All right, so I'm going to pause here. And if anyone has any questions or comments they'd want to bring up, otherwise, I have some questions for the group as well. Yes, please.
Should you stay out of the sun more because you're already getting the UVB rays?
So the question was, I'm going to actually have you say it into here so online can hear as well.
So if you're getting UVB therapy, should you stay out of the sun more because you're already getting UVB rays?
Yeah, so that is a very great question. Ultimately, the long-term studies have shown that for patients that are getting narrowband UVB therapy, their risk of skin cancer doesn't necessarily dramatically increase. But at the end of the day, I think that if you love the sun, you love going outside, that's totally fine. Just you should be a little bit more diligent about oh, I'm getting phototherapy. I need to wear sunblock. I need to be more aware to be in the shade. So it was what I was saying. I don't want you to avoid the sun, but consider it a friend that you want to be next to you. Not super close to, but you can still enjoy it. Yeah.
I have a question from the online audience.
Sure.
And then remind the online audience to use the Q&A tool to ask their questions. Which UV treatment is best for lymphomatoid papulosis?
So it depends on, it's hard to say specifically. I think it depends primarily on the extent of disease and how much you have it. Usually, classically, lymphomatoid papulosis, or LYP as we call it in dermatology, responds pretty well to narrowband UVB therapy. Sometimes PUVA may be recommended. And PUVA has classically been said to penetrate a little bit deeper in the skin. So it might be useful for more of these indurated plaques. But a lot of it is also based upon availability because there aren't many centers in the US that actually offer more than one light modality. Usually it's really just narrowband UVB therapy is used more often. So I don't think there's any head-to-head studies that have shown improvement in one phototherapy versus the other for lymphomatoid papulosis. So you would just have to speak with your local dermatologist or local academic center about that.
Was wondering if there's any evidence of increased skin reaction in the water when you're swimming, if you have had the light treatment. And then also what the effect of chlorine does on the treated skin.
I don't believe I've heard anything about increased light reactivity from water. And also with chlorine, there isn't any studies that have shown that if there's chlorine in the water, you're more sensitized. And I think chlorine, I'm not a pool expert by any means, but chlorine is important for the sanitization, so I don't think that's going anywhere soon. Yeah.
So between the two types of light therapy, PUVA and the narrow band, is there a bit more risk of developing types of skin cancer with one versus the other? I've had both. I had PUVA at the beginning, which was extremely difficult for me at the time because it was tough to find the sorolins. Very, very nauseous. I was to join the narrowband world, but I'd just be interested in your comments. Thank you.
Yeah. I think the long-term studies have shown that there is a slightly higher risk for skin cancer for patients that are undergoing UVA or PUVA therapy, certainly. And we know this. This has been widely reported, and this is what we all are aware of. And so for patients that are especially getting UVA therapy in long term, we monitor them closely. We do skin checks. We make sure that we balance this with their maybe baseline underlying risk of developing skin cancer as well, because if a patient doesn't really have a strong predilection for skin cancer, then we might say, okay, it's fine to continue, but it's certainly something we're concerned about. But in terms of the difference between the two modalities of phototherapy, narrow bands, as you're saying, it tends to be tolerated better. You don't get the nausea from doing the Sorolin, and it's a little bit more safer, and so it's a little better in that regard. But if you have deeper disease, you have more aggressive disease, and you need to do PUVA, then that's what you do, and we just monitor closely in those cases.
All right, I have a few questions online, so we're going to bounce back and forth. Should you wear sunscreen for light therapy specifically?
I would should you wear sunscreen while you're getting the treatment? So that is a great question and a great clarification. So if you are wearing sunblock while you are getting the phototherapy, you're essentially blocking what the phototherapy is trying to do. It's trying to calm down inflammation, and you're kind of screening out the UV therapy. So if your dermatologist has said, you don't need to treat your face, your disease is only on your body, then definitely wear the sunblock on your face, but make sure you're not wearing it when getting the phototherapy, and then afterwards you put sunblock on. So you want to expose the parts that are getting phototherapy, but now you're going outside, wear the sunblock. Yeah.
Hi, I just wanted to follow up on the question about water. And your question, I think, was a swimming pool. But I live in the West Coast and I swim in the ocean, and I find the salt water helps. It helps with it reduces the inflammation. I'm wondering if you had any thoughts on that.
Yes, that is such an interesting point. Essentially, well, for some patients, I've heard going to the water or the ocean water, it's irritating, it's salty, my skin doesn't like it. But for other patients, going onto the ocean is kind of like doing a sitz bath, a very luxurious, salty, like spa day for them. So I think it depends kind of baseline on specific skin types, how well you moisturize on a daily basis, if you're baseline dry, but it depends. Yeah, definitely. Oh.
We'll do an online, then we'll come into the room. What topical medications are good options for LYP?
So I would defer to a dermatologist for that question. There are multiple topical medications you can use, including the same ones that you use for cutaneous lymphoma, topical steroids, great example, calcineurin inhibitors like tacrolimus, pimecrolimus, always very useful. I don't think something like nitrogen mustard gel is used in this case quite often for LYP, but I think that would require a dermatologist to look at the skin and make a measured discussion about the best treatment options for that. Yeah.
I just wanted to follow up on your comment around PUVA, the lady over here. I've had two cycles of PUVA, and it was quite scientific in terms of how they worked out the skin cancer risk, which was something I was concerned when I started on, is like the total number of joules that you
Yeah.
are given during there. And, they reckon that after about 6 treatment cycles, your risk goes up quite significantly, but up to then, it really doesn't change that much. So it did help me to just understand how many, and I'm not a doctor, so I don't, when I'm talking joules, I'm not really talking from, but it was, quite low and then significantly escalated. So they kind of said you could really only have 6 treatment cycles in your life before you have to make a judgment on, does that, significantly increase your risk of skin cancer?
Fantastic, thank you. I'm going to move on because I imagine this next topic that I am going into, people have a lot of opinions on, and so I really wanted to cover that. And so let's move on here. And thank you everyone for your questions. So fact or fiction, diet and the gut microbiome can infect cutaneous lymphoma. Maybe? I don't know. So let's talk a little bit about this, but first, to go into it, I want to bring some key definitions here. So when I talk about the gut microbiome, that refers to the ecosystem of all these different organisms that naturally live in our guts. That includes bacteria, fungi, parasites, viruses that live in your gut. And so it makes sense that this affects our digestive system, but what's been very interesting is that within the past couple of years, people are elucidating out how this ecosystem, this jungle essentially that lives in your gut, affects your immune system, your nervous system, and even your endocrine system, or the hormone signaling in your body. And so the role of the gut microbiome in medicine is a hotly researched topic right now, though I want to highlight one classic example in which we utilize the gut microbiome is in the treatment of a Clostridium difficile infection. We call it a C. diff infection. So this is a really serious infection that hospitalized patients get when they use a lot of antibiotics. What happens is that it clears out all this healthy organisms that are in your gut, and what comes in and what colonizes in is Clostridium difficile, C. diff, and what patients get is essentially life-threatening diarrhea. They get dehydrated, they can't keep any solids down. And so as a sort of Hail Mary treatment that an amazing person thought of a long time ago, they thought, what if we tried to recolonize the gut microbiome? And so what they do is they give stool samples. So they get stools from healthy people, or poop from healthy people, and they give it to these patients. And they found that it actually helps their infection. And so that was almost like a proof of concept that the gut microbiome, if we can harness it and utilize it, it can help in different diseases. And so another key definition here, prebiotics, or this is food or supplements that can feed the gut bacteria, and probiotics are the food or supplements that contain the microbes that help promote health. And the reason I mention this is because I think these words prebiotic and probiotic are thrown out all the time in different messaging and things like that, but just kind of defining out is helpful. So you can think of prebiotics and probiotics have their own role to play in the fight for better gut health. So probiotic foods are the foods and supplements that add soldiers to your army, and prebiotics are the supplies that you need to fuel those soldiers, essentially. All right, so there's one interesting study, and I'm just going to read this title slide, that gut dysbiosis in cutaneous T-cell lymphoma is characterized by shifts in relative abundances of specific bacterial taxa, decreased diversity, and more advanced disease. So what that's basically saying is that in advanced cutaneous T-cell lymphoma, or cutaneous advanced mycosis fungoides in general, they found dysbiosis. And what dysbiosis means is that it has more of the harmful bacteria that haven't been shown to promote health, and less of the more healthy bacteria. And so from the study, they found that in people with advanced disease, that you have less of Coriobateriae, which is found in your gut, Lactobacillus, which is found in yogurt, and Bifidobacterium, which is found in different fermented foods like kimchi, kombucha, and sauerkraut. So this is an interesting correlation, but correlation, we say this in all time in medicine, correlation does not mean causation. So this is an association that they found, but it doesn't mean that if you eat a ton of yogurt, sauerkraut, and kimchi. You're going to cure your disease. That's not what this means at all. It means that what it does mean is that there's more we need to learn and understand because we don't know the association. But I do, if patients want like recommendations on prebiotic foods, how can I feed this gut bacteria? Well, oh, sorry, that was just something that fell from my pocket. There are some foods that you can recommend. And I mean, it's hard to recommend a specific food. I personally just say eat whole grains, whole fruits, like whole vegetables. But here are some examples of prebiotic foods. Asparagus, yum, apples, bananas, leeks, garlic. These are just like whole foods. And I feel like a lot of people do eat these in their day-to-day diet. And the most important thing is to try to avoid processed things, that we're really trying to get like nice fiber to really kind of help your gut here. And of course, like if you want probiotics, as I mentioned, yogurt, sauerkraut, kimchi, kefir, all these things are great. And so I would be amiss to talk about the gut microbiome, but not mention the skin microbiome too. So it's the community of different organisms that live on our skin. And this has been studied a little bit more than the gut microbiome. And it has been shown for many, many years now that if you have more advanced like cutaneous T-cell lymphoma, you tend to have a pathogenic organism that lives on your skin, Staphylococcus aureus, which causes different skin infections, sure. But you also tend to have Staphylococcus epidermidis, which kind of naturally lives on your skin. Those are in higher proportion for people that have CTCL. And so because of this, there's been reports in the 70s and 80s like, hey, maybe an antibacterial treatment should be used for people that have CTCL. Maybe it would be helpful. But it's kind of been sparse. Like many different consensus organizations have gone together and no one really came to a conclusion about using antibiotics for CTCL treatment. So what does this mean, right? It means that we don't know. We don't know, essentially, at the end of the day, how the gut microbiome or treating it, how that affects the progression of disease. And especially, we don't know how the organisms in your gut, how that affects the organisms on your skin and vice versa. So this is not me saying that, if you eat a healthy diet, you're going to fix everything. That's clearly not it. You need to, do your phototherapy, you guys. But I think that if someone is looking for a different holistic way of approaching their disease state, I don't think any doctor is ever going to say like, don't eat fruits and vegetables. It doesn't help, There's so many other benefits to having a healthy gut microbiome. And if, in any case, it can probably only help your disease that I think we can recommend, having a healthy diet should be helpful overall for you. And this kind of goes into my last slide here. And leading into the other sessions here at this conference, I think that it's important to all take a step back and all remember, I think it's wonderful that we have something like this, but we all know that CTCL is quite rare and it can be isolating to live with this disease. And the studies have shown that things like stress can worsen your prognosis, can worsen your disease. And so I think it's wonderful that we have this conference and we have a chance to all meet each other and get to know each other and realize that we have a community out there to support each other. And just recognize how CTCL affects all different aspects of life, from friends, family, employment, hobbies. This really kind of integrates itself all over. And so I'm like for example, very looking forward to learning a little bit more about charcuterie board, how to make one of those. That's so cool. Ultimately, I am very honored to be here, very honored to get to learn from you all. And so thank you so much for having me. That's all I have. So if anyone has any further questions or comments, please feel free to email me, but happy to take any more questions or comments.
So they were really listening to you about sunblock. So one of the questions is, do you have a recommendation on any sunblocks to avoid that can aggravate plaques?
So Great question. I don't think there's any particular sunblock that has been known to worsen cutaneous lymphoma, essentially, right? But if I had to make a recommendation for patients, the most common side effect for using sunblock actually is something we call allergic contact dermatitis, or a reaction against some ingredients in the sunblock. And so this can be secondary to the use of some sunblocks that have some chemical ingredients like oxybenzone or avobenzone. And so in those cases, I'd recommend a patient to use what's called a non-organic sunblock, or a physical sunblock, as it's commonly said, that has like zinc oxide or titanium dioxide as a blocker. I think actually I have a slide about this because I predicted someone might ask about this. So that has these ingredients: zinc oxide or titanium dioxide. Oxybenzone and avobenzone can cause this contact dermatitis, as I mentioned.
We have another,
So after starting phototherapy, I noticed that my skin is peeling and it's getting rough. So is that common, and should I wait before I moisturize so that the effects, sink in, or can I just moisturize right after?
Yes, that's great question. Very, very common side effect from phototherapy. Once you finish your phototherapy, all the effects, they're there. They're in your skin. Moisturize, moisturize, moisturize. We like to tell patients, don't think of it as moisturization. Think of it as greasing up. You have to grease up, grease your body, be shiny, be smooth, fly through the air with your grease. That's what you have to do. Oh, the other thing, for everybody, and Dr. Geskin will have a wonderful talk, I think tomorrow, about skincare tips. But we tell patients, it's a struggle, but moisturizing at least 3 times daily, that's what we recommend. You really want to like trap in all the moisture in your skin, especially here in the winter time. I'm personally new to the East Coast, and it gets dry in the winter, and it's tough. You really have to tackle it. Yeah.
So we do have another question online, but something I want to preface with this is the questions that Dr. Lay is answering for us. He is answering these from his experience. We don't want to consider any of these answers a second opinion. If you want more information on this, please speak to your own clinician on it. So with that, someone has a very specific treatment that a course that they're asking about. So Dr. Lay, if it's not something you're comfortable answering, then it's perfectly acceptable. What are your thoughts about combining a cortisone cream twice weekly with light therapy 3 times weekly to treat patches?
Gotcha. So thank you for that disclaimer, because I cannot provide medical advice because I don't know what your skin looks like, unfortunately. I mean, I would love to meet you, but I just don't know what your skin looks like. But I will say that is a treatment plan that people have recommended. But as we said, you should really consult your clinician to make sure that's something that they would want you to do.
Any in-room questions? Any more online? All right. What'd you say?
Sure.
One more.
So once you have the patches, I'm speaking not for me, but for Mark, the patches that remain, they're not active, but they remain. Can those remain for a long time where they, I'm trying to say on that?
Yeah.
Is that a fair question?
Yeah, no, that's a wonderful question. I think it goes into this overall like thought that patients have when they first get diagnosed with this, like, will this ever go away? Will this disappear? Is this like one patch that's on my stomach or on my buttock or something like that? Is that going to stay forever? And It's hard to say. Ultimately, I think that we do have to tell patients that this is a chronic skin disease, right? We're not necessarily going to, when we think about cures, especially in the cancer world, like we can bring it into remission. Like it could potentially go away, it can disappear, but there's always a chance that it may come back. So if you're talking about a specific patch, it could disappear, but you could have a different patch somewhere else. Yes. There is a large proportion of patients that just get patches. That's all they get. All they get is patches. There's only a very small proportion of patients that eventually progress past the patch phase into the plaque phase. But some patients, they live with patches all their life. Some patients, they say, oh, I've had this one patch on my hip for years and years and years and nothing has happened. Other patients say that this patch disappeared, but a new patch has appeared somewhere else after 5 years. So everyone's story is a little bit different, which makes this very frustrating and also very confusing for a lot of people. So to answer your question, yes, and maybe at the same time.
All right, any last minute questions for Dr. Lay? All right, well, thank you, Dr. Lay. We really appreciate you coming in.